Awesome. Well, thanks for coming to Hugh's talk today, which is going to be on the collaborative care model. And Hugh, do you want to give a bit of intro about yourself and then, teach us what you know?
Absolutely. So, hi everyone. I'm Hugh Barrigan. I'm the CTO and one of the co-founders at Mirah. So we're a behavioral health technology platform who's spent a while in specialty behavioral health, but more recently have been focusing on an integrated model of collaborative called collaborative care, an integrated model of healthcare. And it's mostly on the latter I'm going to be talking to you about today. So with that, assuming that I have permission to share my screen, we will get into it. Perfect. Okay, so here we are today. We're going to talk about a little bit about the integrated care landscape and how we think, and I think particularly that's a lot evolving, and how that's going to change to healthcare provided pretty well everywhere on the spectrum. So I just want to start talking a little bit about why I think integrated care is getting more common right now. And so defining integrated care here being behavioral health care and primary care and other more general medical specialties coming together. And so for those who've been kind of studying their US healthcare history for years, behavioral healthcare has been under mostly a carve-out system where behavioral healthcare is separate. There are separate insurance companies. People like Magellan and Beacon have been providing specific behavioral health services, and that's been in vogue for quite a while. What we've been seeing for these reasons I've got on the slide is that there's a big trend towards pulling primary care back into the mix when it comes to providing mental health care treatment. And the first of those, I think, started in the pandemic, and that's just a lot higher prevalence of behavioral health issues. Some of the studies are showing that in primary care, up to 70% of primary care visits have some level of behavioral health concern or issue that needs addressing. And that's meaning right now it's kind of in primary care's face that they have to deal with this problem. And if they can't get it done with in specialty behavioral health, then they have to deal with it where they are because it's something they're actively having to deal with. The second big reason we're seeing slow progress towards value-based care is that finally the insurance companies are starting to make kind of quality-based contracts more common. And when you think about that, there's a famous stat from the Kennedy Forum that a depressed diabetic is between 2 and 7 times more expensive to treat than someone without a diabetic without the comorbid depression. And that means that when it comes to defining these value contracts, it becomes more obvious that one of the biggest levers available for total medical spend is to treat behavioral health in the same vein as primary care and in the same setting. What this is also leading to is an access problem that has been around for years in behavioral health, which is it's very difficult to get access to behavioral health from primary care. The average person waits almost 7 years from onset of symptoms into actual specialty behavioral treatment, by which time moderate issues have become severe, mild issues have become moderate. And so it just is causing kind of a pipeline problem. And what that happens in the end is that you go into a primary health visit and you say, I have a behavioral health issue, and the primary care doctor is offering you a list of 50 people to call, none of whom have space to take you. And this is what's causing the upstream problems with access to behavioral health care. The final part about this is more nuanced and vague, but it's basically about parity laws. There are supposed to be enshrined in law parity between behavioral health and general medical services. In actuality, particularly given the way that the codes are done, that's not proving to be true. And so all of these reasons mean that behavioral health is starting to become more thought about in primary care, and that's going to lead to a more integrated model of care. Do feel free to throw questions as I go. I will kind of take a pause at the moment of every slide. Okay, so then we're going to move to talk about what this change in the landscape means for a variety of people in the system. I'm going to start with classic behavioral health providers. There's a continuing lack of strong reimbursement. Kind of the average raises are kind of sub-inflationary on a lot of behavioral health therapy codes, while a lot of these new integrated care codes are extremely well reimbursed. And in fact, in some cases, it's even more profitable to take a therapist, stop billing them for therapy, and instead bill them for an integrated care code instead. That's kind of the paucity and difference in codes. And at some level, I'd say that's CMS putting their fingers on the scale about how and where they would like care to be practiced. If they're authorizing these codes and they're authorized extremely robustly inside of of primary care, and the behavioral health codes are continuing as they are, that's really a strong signal of what that's going to mean for the industry. If this continues to happen, what's going to happen is that more behavioral health care will be practiced inside of primary care, and less will be practiced in specialty behavioral health, which is going to have a knock-on impact to the referral flow into this classic outpatient behavioral health treatment. It's going to mean there are fewer referrals, and they're more of a higher acuity, higher severity, which means they're going to be more difficult to treat, which means they're going to be knock-on impacts to things like clinician burnout, as they're going to be treating a more kind of severe case mix. And so this could be a real landscape change for how behavioral health providers think about their industry and their craft. What this means for payers. So this actually means less for payers. The payers have already turned most of these codes on. And so most states and most payers, commercial payers and Medicare and Medicaid, have codes for integrated care turned on, and they're well reimbursed. There's still some kinks coming out in some of them, but the kind of, if you think about, the payers have the one lever in how to change the direction of care, and that's authorize the codes and put it on the rate sheet. They've already done that. It is going to mean a tough time for those payers like Beacon, etc., who are still operating as a specialty carve-out. It's going to be tough times for them, because we're seeing kind of like an almost existential threat as behavioral health is being taken back from the carve-outs into general medical insurance. And finally, why are they all doing it? It's because the research for these integrated care, and particularly collaborative care, which we're going to move on to in a second, indicates a lower total patient cost while improving patient outcomes. And so in theory, that's why the payers have authorized it, because they like this and they're trying to incentivize it. Now, this wouldn't be an XPC talk without mentioning DPC. And like, in honesty, I don't know what this means for direct primary care. I think it's a great model, and the integrated is a good thing. Most of the things we see on the way this is playing out in the market right now are specific to value-based and capitated rates and the fee-for-service market. So maybe that's a later discussion of what this means and whether or not it's a good idea to put it in DPC. Okay. Final thing to say is, how do we go from integrated care is a good idea to collaborative care as a model is a good idea? And we'll talk about it in more detail in a second, but collaborative care is currently the best way of doing integrated care according to the research. And that's going to hit all of the parts of the quadruple aim, and we're going to talk about each of them in sequence. Any questions so far? Okay, so then what is collaborative care? Put simply, it's an integrated model of behavioral health care. So we're talking about taking behavioral health resources and putting them embedded into primary care and other general medical specialties, where instead of having to get a separate referral and have an entire separate treatment team, you're talking about embedding behavioral health resources and treating people's behavioral health concerns right where they are, not as a specialty subject. The collaborative care model is a specific model of that. It has elements of service that we'll talk about, and it's a particular way of doing things, but at heart, it's just one model of integrated care above several. What brings it out and puts it to the top of the pack is that it is specifically authorized for a set of codes by CMS and all the major insurance companies. And that's happened because it has the largest evidence base for its efficacy, both in terms of total expenditure, in terms of system costs, and in terms of the outcomes of patients going through a collaborative care program. And it is the one with the most widely available reimbursement, which makes a difference to the majority of the practices in the United States, which are still fee-for-service. So that's what it is. We're going to get into the details next. Any questions so far? Okay. So I'm going to delay talking about actually what it looks like and talk about what people like in general for it and why people are excited by it. And hopefully that'll provide context for the specifics of the model. So first, I want to talk about why provider organizations are very excited by collaborative care. The first, and some of this touches on what we talked about earlier, having better, more timely access to behavioral health care is crucial. You don't have to wait 6 months for a referral out to the psychiatrist or the psychologist. The aim is to get people treatment for their behavioral concern while they're mild and moderate within days of diagnosis, so that you can kind of, push the lever at the right time so you don't have to apply as much effort. This leads to better outcomes for patients. It's easier to treat mild and moderate depression, for example, than it is to wait until a patient is very depressed and then have to refer them out to specialty care. Specifically for fee-for-service, these codes can be fairly vastly revenue generating. It is possible to make money doing integrated care using the new codes. And finally, when you ask PCPs who've been part of a model of integrated care, particularly the collaborative care model, really very much enjoy doing it. It means they have built-in support for the issues which are now increasingly troubling them. That earlier stat of 70% of patients presenting with some kind of behavioral health comorbidity, they have additional to support to deal with that in the moment and know that patients are getting better because of their support that they have. So just to make a kind of double down on why the PCPs' lives get easier, one of the things we're going to talk about in the model in a second is the consultant psychiatrist or psychiatric consultant role, which is going to bring behavioral health specialty knowledge at an MD level into primary care. So about 70% of antidepressants are prescribed from primary care. And a lot of those doctors don't know what the next thing is. They don't know how to titrate the doses for these medications. They don't necessarily have experience with dealing with a lot of the less common psychiatric medication. And having a specialty psychiatrist to help them through those cases can be extremely valuable. It lets them focus on what they're doing. It stops them, for example, having to respond to a whole lot of MyChart messages from patients with behavioral health needs. Someone on the care team with a behavioral health specialty can do that for them, which lets them basically spend more time at the top of their license. They get better, and it saves them time because they're having to kind of, I think the studies show that PCPs in a collaborative care model save on average 2 minutes per appointment per day. They're just able to make sure they can keep to the schedule better. Okay. So enough about kind of why do people do it? What does it actually look like? So there are 4 main roles in the collaborative care model. Just to kind of go to the ones that are already present there, we've got the primary care provider. Now, just to be clear, it doesn't have to be directly in primary care. We're also seeing collaborative care models work in oncology and nephrology and other specialties which have like a hub of treatment. But for the rest of this talk, given it's primary care, I'm going to focus on the primary care provider. The most crucial new role in the model is this care manager. If you're familiar with CCM chronic care management, a lot of the way that this works is kind of similar to some of those other codes like CCM. But for the collaborative care model, we're talking about a care manager being a bachelor's level professional, possibly, or sometimes master's. It depends on the state and it depends on how you choose to staff it, who's going to be effectively the arms and legs, the air traffic control of this whole thing. They're going to do a variety of tasks that both make the PCP's life easier and guide treatment for the patient. We've got that consultant psychiatrist that I was talking about earlier, who's the specialty part of it, who's really truly a consultant. Sometimes, most of the time, they don't even know the patient's names. They're just providing case review and advice to the PCPs. And then in some models, we've got a true behavioral health licensed therapist on staff providing completely integrated care. And all of them work together something like this. Ultimately, the PCP is responsible for care, and the rest of the care team is there to support them. The care manager is, as I said earlier, thinking about this like traffic control. We're thinking about things like behavioral health activation, sleep hygiene review, chasing down, especially in pediatric populations, chasing down the schools, and kind of talking to the school about getting an IEP, all of those kind of blocking and tackling things that the PCP or someone was having to do, those tasks are now billable. And we'll talk about the requirements for reimbursement at the end when I kind of like finish the elements of service. This model works well in adults, it works well in pediatrics, but is less well studied. It basically works well wherever there's a set of coordination activities to be done and a set of mild evidence-based practices that can be used. I will take the questions as they come, I guess. How does it work when practices already have e-consults in place? So if they already have psychiatric e-consults in place, effectively that could be used as part of, with a few minor changes. One of the elements of service for reimbursement is a standing consultation meeting with the psychiatric consultant, where the caseload is discussed, and there is a formal mechanism for like examining the caseload and saying, who do we want to talk about today? So within that remit, the existing eConsult framework could probably meet many of the conditions for billing immediately, assuming that it actually kind of met the specific elements of service. Does that make sense? In terms of reimbursement requirements while I'm here, virtual or async, as of currently right now, thanks to the pandemic rules, there has been a waiver placed on the in-person requirement. So it is a full virtual service, and increasingly people are billing full virtual. I'm not 100% sure, but I think technically there is a waiver that could expire, and that you may have to have the ability, but not the requirement to see the patient in person. So some states you have to kind of at least be able to see them if they want it, and that will change the staffing model. There are kind of two very different ways that the same ways that the model ends up working. One is pure remote, where it's literally like dial a care manager on the other end of the phone and you never see them. And the other is full on site. They're with you every day in the team huddle in the morning. And both of those models have proven to be successful. That being said, so this is the kind of what the standard model. In the real world, things tend to, as they tend to be a little bit more complicated. And so we've just added a couple of extra bits here in the way that we think about the world. The first is that, particularly for high-risk populations, there tend to be a lot of additional stakeholders involved. Caregivers, teachers, kind of other members of staff, all of these things need to, the idea of collaborative care is collaborative care, and you're looking to get all this input from a load of different people. And so those need to be brought into the collaborative care model too in some way. And that really is by interacting with the care manager. The care manager is calling the kids calling the caregivers in a pediatric population, or otherwise coordinating with external referrals or other therapists, etc. The other thing here is that quite often you see this blend of the care manager and the therapist both acting as a kind of care management team, where the therapist can bill time or as a normal therapy appointment, or bill collaborative care minutes. And we'll talk about what that looks like in a second. The final bit just I hadn't mentioned, one of the actual requirements in the billing codes is for what's called a registry, a kind of a technology product to keep track of patient status and do a variety of things. And that's effectively where the Mirah part comes in. We provide the registry, as well as often this is a new model and people need a bit of help getting out of their own way to understand how the model actually works and implement adequately. All right. Any questions so far? Okay. So this is all a little bit abstract. I want to bring it down into what this actually means in a brief anecdote. So let's start out with a situation without collaborative care in place. There's the hand on the doorknob moment, as I believe it's called, where you have your appointment, it's their annual checkup, and just as they get up, your hand's on the doorknob and they say, I think I'm depressed. And now you have to work out what you're going to do. This is exactly what throws off your appointments. And you have to work out how you're going to help them. Are you going to diagnose them? Are you going to refer them out to specialty care? How is this going to work? Because you know that you're going to give them a list of names. They're going to call most of them. They're going to have no success. So that's kind of the old unintegrated way. What does it look like with collaborative care? I'm going to focus on a collaborative care intervention where it is on site with a warm handoff. So you've got the care manager there in the next room. So now when the hand on the doorknob moment happens and they say, I think I may be depressed, you bring in the care manager, whose job is to then walk them through what it's like to be in a collaborative care program, what the goals are, what the kind of first set of small evidence-based practices are. They're going to sit there and chat to them while you, the PCP, go off to your next appointment and stay on time. All of this is billable in a fee-for-service model because these are time-based codes. So the way these codes work in general is that they are monthly billed accrual codes, like chronic care management, where you spend 3 minutes here, you spend 5 minutes there. If you hit certain billable thresholds at the end of a month, then you can bill for the entire month. So the second they're in, The care manager is walking them through an intervention. They're saying what's going to be expected of them, that they're going to be in contact several times throughout the month. They're going to take some behavioral health assessments so they can track their progress. We're going to do this psychosocial history. We are going to do a couple of evidence-based practices in order to reduce your depression. They then go straight off after that, and then the care manager's job is to keep track of them throughout that month, keep them on track, and then nudge them at the right time into the right services. So what this leads to in the end is an intervention on average, probably 5 or 6 months, where a patient comes in with mild or moderate depression or anxiety, and then sees complete remission in that 5 to 6 month period. And so the idea is you're treating them ahead of the funnel, where you're stopping them before the comorbidities happen and before it gets difficult and expensive to treat. So what do you actually need to make this work as a holistic intervention? I already mentioned the registry. That's the kind of bit listed in the CMS codes as the kind of the tracking of the active patient caseload and current status. You need an assessment engine to deliver behavioral health assessments. One of the elements of service is regular monthly, I think it's defined as monthly behavioral health measurement using a standardized instrument. So for those familiar with that, we're talking about things like measurement on the PHQ-9 or the GAD-7 traditionally in an adult population. That gets a lot more interesting when you're talking about either less common diagnoses or younger or older populations. So for example, the collaborative care model has been shown to work in young children, but you have to measure on something different. The young child can't fill out the PHQ-9 for themselves. There has to be a different assessment, which is helping measure their overall treatment progress. Both for the reasons of providing a standardized level of care and being able to adequately document the time spent in the collaborative care model for billing purposes, you need to provide time and task tracking so that firstly, you can nudge the right task at the right time. A lot of the people who are being care managers, this is potentially their first job out of school. Some of them are potentially have never had a job in behavioral health or healthcare before. Some are master's level clinicians who are not yet licensed and are still doing their licensure work. They need probably a little bit more hand-holding sometimes than the average master's level clinician. And so that being able to guide them through what they should be doing is important, and then making sure you have the minutes on top of it to manage it. So those are kind of technological components. There are two major components which are non-technological. The first, like any large practice in the way that you operate, is an organizational change component, where this is a new model of care. There are new people. The PCP is going to have to do things differently, and anything like that always needs to be a little bit carefully stage managed. So making no bones about it, this is not a drag and drop tech solution or anything like that. This is a change to the way you practice, and you should expect to see change, positive, we hope, changes to the way you practice. And the first is just to acknowledge that this is a new role that you are staffing for. So if you're a primary care practice who has never hired a behavioral health clinician before, that is a learning curve that you're going to have to get up. Like, you're going to have to work out what the job descriptions look like. You're going to have to work out what looks like a good hire and how you're going to supervise them. And then you're going to have to put it all together. So let's talk about the kind of the difficulties in the model and who's resistant to it. Fear and uncertainty is the biggest element when you're asking a primary care doc to change the way that they practice. And what you see in the field is that once a primary care doc has seen it and enjoys it, they become mostly an advocate for it. And what we're seeing is a spread as people become more familiar with the model, that they are more comfortable talking about it. And so there's always a resistance to doing anything that is unknown. And what you have to do is counter with the research base and the kind of show it how it works and get kind of champions involved, all the usual classic change strategy. But usually it is the primary care, it's the PCP who is most resistant. Who is resistant to the care model? So, great question. And in full transparency, I think the research is still growing on where it's most effective and least effective. Most of the evidence base in the early days, so there's a center called the Ames Center in Washington, who has been doing most of the research, on the academic research on this, and they've mostly focused to begin with on adult anxiety and depression. And it seems to be very effective, proven for adult anxiety and depression. It's particularly effective in the mild and moderate end. If you have a severe patient, they probably still need to be referred out to specialty care, because a bachelor's level care manager is not able to provide the appropriate level of evidence-based practice to get a very severe depressive patient into a happier place. You can actually use the collaborative care model to almost provide touch points, kind of like a thread from primary care to behavioral health. But there are a couple of reasons why that doesn't always happen. The first is that in some states, if you're actually being seen in specialty behavioral health, then they will not reimburse the codes, which I think is actually a terrible mistake, because it completely kills the continuity of care between primary care and behavioral health. Off the top of my head, I'm not sure which states. I will have to follow up on that. I have a database somewhere. And the other reason is that it's quite just expensive to carry those patients if they're not getting better, because that means that they're thinking about this as an access problem. The more patients that you keep for 2 years rather than treat and cure in 6 months, that reduces your ability to serve other patients who are coming into the model. Any more questions? If I missed any questions? Tech stack. Okay. So like all good healthcare technology, the tech stack for this is actually fairly boring, in the sense that most of the problems we're solving here are not really technical problems, but instead are technology in the search of solving an organizational problem. So not to say our tech stack doesn't do a whole lot of cool things, like the automated assessment tracking, all of the kind of task list management and the nudges about what tasks to do at what time, but I want to be clear, we're not kind of reinventing nuclear fusion here. This is mostly around making it integrate well. The skill is making it integrate well with existing workflows, because that's what really matters at the end of the day. The more additional tech products you add to any healthcare worker's life, the worse their life gets. And so we kind of tend to think about it as a fairly high barrier to entry to really be able to say this is worth it to do this as an external thing. And actually, just to be clear, Mirah is not the only registry out there. Epic, for example, has a registry as part of their tech stack, but what it's not is very good. And so there's always a trade-off here between having a really high quality solution which optimizes for one thing and having one tool that does it all, and that continues to play out in build versus buy decisions across the country. You can technically do the collaborative care model with a spreadsheet. You can have an Excel spreadsheet which just has a list of patients and their last PHQ-9 score, and that technically will meet the requirements for billing. But what it won't do is A, be very effective at maintaining a caseload, and we'll talk about the financials in a second. And B, you're going to do a lot of manual data entry, and the user satisfaction is not very high. Okay, let's just talk about the fee-for-service financials for a second, just in case that's useful. So the three major codes used to bill this are 99492, 99493, and 99494. As I said, these are all time-based services, monthly accrual codes. When it comes to the economics of the model, staffing is by far the largest cost component. You're talking about hiring new staff and paying them whether or not you get reimbursed. Most of the time, in most states, these are 60 and 70-minute codes, which means under most states being the 1/2+1 rule, you can start billing at 31 or 36 minutes, depending on the month. That's the month of treatment, like month 1, month 2 of treatment, which when you add it all together means that the number of patients that each care manager can support is the largest single financial element of whether or not this program makes sense and can self-sustain, or whether or not it needs to be grant funded or will fail. So as benchmarks, think if you're using a spreadsheet, you can maybe do 40 patients at a time. If you are using something like Epic's registry and you haven't really kitted it out, or some level of better technology, but not great technology, maybe 60 to 70, and that tends to like roughly around break even. And then good registries can get you probably to 100, maybe 100 plus under certain circumstances and the correct caseload, which will then let you turn it into a revenue generating opportunity. There is actually enough play in the model where it is not always with our customer base needed to be revenue generating. They're just looking for it to break even, and they're quite happy to do things that make more sense for the rest of the population than on a pure fee-for-service background where they are trying to optimize every cent. Okay, that's a lot of talking by me. Any more questions so far? And did I miss anyone's question?
Well, I think you did a pretty good job. Aaron, do you feel like your question was answered pretty well about the types of patients? You might have stepped away for a second. You know, my what I was wondering is, you know, you said Excel spreadsheets are pretty onerous. What like, you know, a lot of AI tools being embedded are making a lot of the onerous tasks simpler. And if staffing, you know, so that's one thing. It's, you know, is that just simplify the entire technology need? And then kind of related, if the staffing costs are most expensive and a lot of it is admin work and like coordination, do you see that cost dropping significantly with utilization of, you know, all of the AI enabled stuff?
It's a great question. I think that AI has a role to play in collaborative care, but I'm not convinced it's a huge role, in the sense that, and let me break that down into the why. In the short term, the way that the fee-for-service codes are worded means that as long as you spend kind of appropriately the right amount of time, it doesn't matter if you're doing incredibly high value activities or tapping up notes. They're both accrual, you know, minutes accrual. And so it's not like from a purely fee-for-service background that suddenly if all of your note taking went to zero, that would change your financials. You'd be able to provide better outcomes because you'd hopefully spend more time on high value activities, but you wouldn't be suddenly like going home earlier in the day or being able to bill more patients probably. And so that's on the fee-for-service side, that's going to limit how we think about those tools. Now, the collaborative care model is also proven in value-based arrangements where that is potentially more interesting. So just to kind of take out the second level of where it could provide value, there is a certain amount of kind of note generation, et cetera. And so like listening to the phone call with the patient and doing a note summary on that probably actually provides value rather than spending, you know, 2 or 3 minutes writing up the notes, or potentially more writing up the notes of the call as you go. So I do think there's an opportunity for kind of that bookkeeping style. The people using spreadsheets, it's the duplicate data entry and having to copy around and having all these different sheets and different times and kind of keeping track of it that causes the problem. And so really, that is a kind of a different mode to the AI, where the AI is integrated into the tool stack and is doing things. Like you get a lot of benefits, not with AI, but just having it integrated. So for example, when you want to enroll a collaborative care patient in the registry, they're already there. You just have to hit a button rather than you have to copy their details back. Or for example, if you're generating notes from the care plan you've done on the basis of your assessment results, that's going to copy back into the EHR automatically rather than you have to do it. So that's, in some senses, more of a plumbing issue than an AI issue, if that makes sense. Like you have to still have the data pipes with the appropriate data being transferred, and the content is where the AI would live, which will save some minutes, but really, you don't need AI to have it smooth, I would basically say, but it will save money on the edge. Well, save time and provide better quality on the edge.
This is helpful. Yeah. And what do you think about group visits? trying to scale this?
I think so. Let's split this into the kind of fee for service and value-based care arms. The fee
Mhm.
for service, you are obviously not allowed to double count for anyone. And so the issue for group visits for collaborative care is that, as far as I'm aware, if you're a care manager and you are kind of doing a group visit with 5 people, you can only accrue minutes for one of them, which from a fee for service thing makes the whole thing dead in the water, right? Like you can't effectively double dip for it. So those codes are not designed for that. They're designed to be in a individualized patient attention mode. So I think that collaborative care and fee for service and group visits not going to get along very well. That being said, what collaborative care effectively does is give you, on the value-based and maybe even the DPC side, an extra set of arms and legs that let everyone teach and like practice at the top of their license. And so if group visits are effective, and it's effective to staff them with the care manager at some level, then collaborative care can be a vehicle to do tasks like that that make sense for your holistic care model beyond collaborative care, if that makes sense. Like in some sense, it's an extra set of arms and legs to do useful tasks. And if you can find, and if it can be funded and like the total cost of the system is, the ROI on the system is positive, then yes, use the care manager for those.
Do you feel like the barrier to entry to do this for others is pretty low?
Others being,
You know, someone with an idea, a friend who can do care management and a friend who's a psychiatrist and a spreadsheet.
to offer care or
Yeah, like
to
to just to be
yeah.
able to execute on a collaborative care model, right? Like, because
Yeah, so I just, you don't mean like on a like kind of like compete with Mirah on the registry you're talking about to provide care. No, so like I think, or I mean, I'm happy to answer either.
yeah, I would say actually either would be interesting to hear.
Well, let me start with the Mirah side. It's easy to make something that looks like it might do collaborative care well, and it's difficult to do something that actually does collaborative care well. And so the results in the end, like the ROI, the stats like the number of patients that each care manager gets to, that's the ultimate proof in the pudding from a kind of competitive aspect. You can do it with a spreadsheet, but you should choose something that actually makes ROI sense, and the better registries will do that. The more interesting question is probably the one about, can any man in a plan and a psychiatrist come and do this? And the answer is yes, and they should. Like, so we're actually partnering with an increasing number of behavioral health organizations who, going back to kind of the very first slide here, or the second slide rather, who kind of see the writing on the wall here, and they see that things are going to change in the behavioral health ecosystem. That right now PCPs don't know how to hire behavioral health, and they're reacting to this problem. They're scrambling for it, but they're not very good at hiring behavioral health clinicians. They've never really done it. And so they're getting interested in doing this, where they can take their existing expertise on the behavioral health side, go and partner with primary care, and then do a revenue share or something, or kind of like find an appropriate billing mechanism where everyone's thrilled, where the primary care is getting all this expertise in things that they didn't have, their patients are getting better faster, and they're making money, while the behavioral health provider is being able to expand, see newer sources of revenue coming from a different place at a higher reimbursement rate, and both sides are very happy with it.
And are you seeing that this is being embedded in training? For example, in my residency, we had a clinical psychologist that was in the precepting room. And so we always had that resource. We never build collaborative care billing codes, but we essentially did that, in different ways. And had it been more formalized as part of just becoming a physician, right? Like that, I think that there's a lot more uptake in that. Do you see anyone, trying to dominate the space?
I was talking to a health system the other day, and they said, I mean, people have been trying to do integrated care and things like this for years, and that they had kind of got the model fully going, and they had a like a full psychiatrist, not one psychiatrist, but like on shift psychiatrists providing full coverage to a number to provide this. And in total, they received about 1 call a month for this health system, where like they effectively had a full-time psychiatrist for 1 call a month. All of which to say, people have been trying this for a while. Until there's a kind of, the thing that makes collaborative care stick is it's kind of a set of instructions on how to do it in a way that works for everyone and that can be trained to. And so when it comes to beginning to train for it, the most interesting part of actually the model, just to kind of skip around the deck here, the bit that really needs training is the care manager. Because one of the great benefits of the model is because the codes were explicitly written to be a bachelor's level paraprofessional, not a licensed mental health clinician. That means there's a whole new source to get out of the access problem. That is, we don't have enough behavioral health clinicians to treat the demand. You can then start using this like an entire ancillary workforce, which also has the massive benefit of being more representative of the populations who need care. It's likely to train care managers from minority communities than it is to kind of get them through a full licensing, where kind of, therapists tend to skew white. So there is effectively a pipeline of new care managers who are being trained explicitly for this. And I think places are starting to kind of deliver care manager training courses explicitly for this. I haven't seen a whole lot of evidence yet that, the average med school resident is being schooled in collaborative care right now as something they should expect coming out. I think that's probably a few years down the pipe yet. Like once the model gains a certain amount of critical mass, it will become hopefully standard practice everywhere.
I'm going to keep asking questions if others don't have any. Cool. All right. So you mentioned the codes. Do you know what do insurers, payers reimburse them fairly differently, or it's a standard amount that's expected?
It's the usual mishmash. Commercial tends to bill better than Medicare and Medicaid. Some states are higher than others. Like California is exceptionally generous, and like California is the high watermark. The top commercial plans in California, you're talking about almost $500 a month for 30 minutes of time, which you can very easily make a collaborative care profitable in California. And then right down on the Medicaid end of the spectrum, it gets a bit tighter. You're probably talking about codes in the $80, $90 a month per patient.
I'll jump in. I'm going to ask the really stupid question, because this is the thing that has always not clicked in terms of the way I would see myself as a patient in the collaborative care model. But I don't understand the point of the care manager in a low acuity patient when they have the ability to self-serve in mental health care. I understand that like passing information back between the primary care provider and, all these parties is great, but essentially all this stuff can be automated to some extent. So what, other than billing and making money and fee for service, et cetera, what is the point that the care manager serves when like we live in a world where most of this stuff should essentially just be seamless?
Great question. I think this actually wouldn't be XPC without more talk of DPC. That relationship, that actual human relationship with healthcare is something that people are always seeking. And as MDs have become more specialized and more expensive, et cetera, it's become tougher and tougher to have a relationship with your MD. People do have a relationship with their care manager. It is someone when they're responding to the MyChart messages, and they're the one who's doing that, and they're the one who's checking in on them and calling to see how they're doing and looking at their treatment plan. There is a large benefit of having a personalized aspect to it, which is actually not to say that the self-serve aspects are not powerful too, but the take-up rate for those self-serve aspects isn't necessarily great. And these can be blended, right? One of the things, if the care manager is just there and they're getting them into the right care, they're nudging them to the right self-service, and then the patient is serving themselves, that's still actually a great system benefit. If you had like 1 month of collaborative care where you got them in to the self-serve and you made sure they had the resources they need to be successful, and then stop billing after that, and they self-serve themselves the way through to success, then fantastic.
Awesome. Thank you.
Evan, I know you made some comments in the chat. Don't know if you want to fill in more on the details, or that was it.
That was basically it. I mean, it was kind of the leading question into the more edgy questions.
Perfect. Yeah. Now, earlier you mentioned that PCPs tend to be the most resistant to incorporating or just to change. What is there anything particular that you've seen helps influence, a change of heart and trying this model, or does it just have to be the right season?
So someone they know and respect saying, no, you should do it is great. Obviously, it's the number one thing that most of these things actually will make them smoother, right? So other PCPs who are like, you should really try it. Don't worry, it's going to be great. Failing that, there is a certain amount of forcing the horse to water until they drink kind of vibe where this is happening. I mean, this is obviously a very different relationship if you're in a health system and you're talking about a negotiation between the health system and the physicians group and a small PCP who's doing it, because they tend to be actually more focused on the business side. Those PCPs who are like PCP businessmen, they're looking at the financial side anyway, and basically they're like, I can increase my patient outcomes, I can get access to those who need it, and I can make money, sign me up. And so, that's a very different vibe to the machinations of the health system. I mean, I just go back to it. If you can get them to understand that this is what makes their life easier, then usually one of them will eventually hit. What they're worried about, when done well, collaborative care should save you time. But a lot of interventions that PCPs have to do, or like just random stuff that comes up, is going to cost them time. And so this is one of those where effectively you're giving me $1 now and I'll give you $10 6 months from now. They still have to give me the $1. They have to give me the training time. They have to give me the attention. And so getting over that hurdle is the really important part. They are going to have to invest a little bit into it to make it work. It's not just going to be it like comes for free. But what happens is usually if they can get a couple of cases referred out in the first week, and then they can immediately feel the weight lifting off them, where they realize they'd have previously had to deal with that case, and now the care manager's dealing with that case, suddenly they're all on board.
So this is maybe something that is already being done, but if this works with such great confidence, why isn't there an entity to basically like arbitrage, saying that, okay, like I'll, almost like be the impact VC, so to speak, where you bankroll the PCP and then keep the difference because it's going to be net positive?
So firstly, a few reasons. And firstly, it kind of is happening. There are a lot of VC startups in the space evaluating a lot of different ones, like, VC backed startups in nephrology, in rhinology, there's just a whole lot of things going on about VC backed startups trying to do exactly this. And so that may well in fact just happen. The billing needs to be done through the PCP. And so there's only a limited amount of arbitrage that can be done directly, because effectively the PCP is responsible for the billing at the end of the day. And so you can come up with arrangements for this. You can kind of try and contract it in where we'll give you the resources and you'll bill what you can and we get a certain percentage of it, but like you can't just outsource the whole thing. And finally, we're still early enough in the journey that staffing is actually the shortage, because I'd mentioned earlier how you got these bachelor's level folks who are coming in. They still need to be trained. Like there are places emerging which are doing that training, but it's not like we have 200,000 care managers ready to go right now. And the folks that are licensed are already incredibly engaged. Like that's the existing access problem we have. So those like master's level therapists who could be parachuted in to do collaborative care tomorrow are already 100% engaged. And so we're seeing that loosen up, but it's not like you could go hire 100,000 care managers and swamp the whole market tomorrow.
Yeah, very interesting. Now,
and I'm sorry, and the final part is just like the mechanics of sales is we have a very fragmented system, and you would have to sell to every PCP in all 250,000 PCPs in the country. And so that's just going to take, and each one of those is a separate sales cycle, and that will just take a certain amount of effort too.
I'm curious now if you can talk about macro trends. How much penetration is there of these models across the, like the small practices, for example?
It's difficult to know precisely, and it's been growing year after year. We're now at the point where, and my stats may be off because I didn't prep those stats, but we're into the hundreds of millions a year in billable collaborative care on those codes. So that is still a drop in the bucket compared to some of the major ones, but it's also like a non-trivial amount. And so penetration of the collaborative care model is still probably, I would guess, well, penetration of integrated care models is higher than that of the collaborative care model. People have been doing it for years. Like a lot of the major health systems have some level of integrated care model. They're funding out of their back pocket, or weirdly. Collaborative care as intervention is probably still, I don't know, off the top of my head, 2% coverage for the population.
Yeah, that's super low.
I mean, the codes were only authorized by CMS in 2017, 2018. And they only hit commercial plans in 2020, the first commercial plans in 2020, 2021, maybe. And so effectively the entire commercial scene is less than 3 years old.
And, theoretically, based on the need and the intervention, like you could get every PCP practice to be in this model, right? If you had enough supply.
I mean, my company's goal is, this is currently the best evidence model for integrated healthcare that we have, as well as being financially sustainable. This is effectively the standard of care, and it should be available for every person in the United States. Until we can find a better model, and then we should do that instead.
Yeah, it's pretty fascinating. So we're approaching top of the hour. I'm going to pause the recording and we can chat for a bit if people have off the record questions. But thanks so much, Hugh. This has been great.
Thank you all.